So next up is going to be Dr. Spencer Krane. Dr. Spencer Krane, he completed his medical school at Tulane University School of Medicine, as did I. But then he completed a robotic urology fellowship at Henry Ford Hospital in Michigan, which I did not. And then he went on to do his urology residency at Wake Forest University. Afterwards, he went up to Bethesda, Maryland, where he worked as a fellow at the National Cancer Institute. But we were fortunate that he came back down here to Louisiana, where he currently serves as the chief of genitourinary surgery at the VA hospital here, and he is also staff urologist at Toro Hospital. And he has a real clinical focus on minimally invasive treatments for urologic malignancies. And he's also just a real recognized expert in the variety of ablative technologies for prostate cancer. He's published extensively on prostate cancer and other genitourinary malignancies, particularly regarding the role of multiparametric MR imaging in the diagnosis and risk stratification of prostate cancer. And he's also successfully secured national funding to assess disparities in screening and trust in African American patients. So, Dr. Spencer Krane.
Thank you, Brian. Once again, you guys will be disappointed with this. I don't think Dr. Einstein was, I think he was selling himself on that one, but with me, it really is. But importantly, and I think this is really true here, I hadn't been at this conference before, and I think Chad and the team here have done a really great job of bringing together and really focusing on what we really want to do here is collaborate between both industry and folks, treating physicians, and then bringing some educational aspects to it as well to really improve in terms of getting better care for our patients, particularly here in South Louisiana, where we have these major issues with disparities and worse cancer outcomes. And so it's really a pleasure just to be here to participate in this. Like I said, I'm the chief of the VA service here, surgery here. I have a couple of disclosures. They're all basically prostate related. One's I've been a speaker for HIFU prostate services, Exact Sciences, and angiodynamics. I'm not going to speak directly about any of those in this talk today. But the focus of my talk today really is going to be talking about what do we do with men who have localized intermediate risk prostate cancer. And when these men come into my clinic, I tell them, congratulations, you have the absolute worst cancer diagnosis. And not because it's a bad cancer diagnosis. There's cancers that kill you much, much faster and more aggressively and with worse outcomes. The problem here is that these patients are saddled with the issues associated with disease choice. There are all sorts of options sitting for these patients. And these patients have a disease that won't hurt them for an extended period of time, and the decisions that they make now will ultimately affect their overall life expectancy and quality of life for the next 20 years that they're on this planet. And that's a lot to sit there with, especially with so much up in the air. None of us have crystal balls to assess this, and it's really difficult that. So in thinking about this, I think there's a couple of things that we need to first do. And the first is just identifying who we think is truly intermediate risk patients and identifying that subset of patients. When we do that, I think the next thing we need to do is really assess how treatments affect patients and what they see following therapy. Once we do that, we can look and really dive and we'll get deep into the nitty-gritty here on oncologic efficacy of treatment of localized prostate cancer. And then once we're able to do that, I think that we can take a step back and look and see what really personalized therapy is in this subset of patients. When going down to define intermediate risk prostate cancer, I think the best definitions are the NCCN guidelines, and that's based off the D'Amico data. And these are patients who must have at least one intermediate risk factor. That's a PSA between 10 or 20, clinical, no high-risk features, or primary grade 2 or 3 within their tissue. Now, in these patients, if they only have one of these, we technically encourage them to be favorable intermediate risk subset of patients. And then the unfavorable intermediate risk patients are the ones that have at least 2 of these, but without any of the high-risk features. And so it's a pretty heterogeneous group because sometimes you'll have patients who have 3+3 disease on their biopsy, but their PSA is 13 who fall into this, who's probably a very different patient than a patient who has 1 or 2 cores of 4+3 disease, and they technically fall into the unfavorable intermediate risk subset of patients. Like I said before, the options for these patients are substantial. And when a patient's sitting there across the room from me trying to make decisions, when you have either favorable or unfavorable intermediate risk disease, you have essentially everything on the docket in front of you. For men with favorable disease, the NCCN recommends active surveillance potentially, external beam radiotherapy or brachytherapy, radical prostatectomy plus or minus a pelvic lymph node dissection. Or if we don't think that you're going to live 10 years, then we can do nothing or EBRT or brachytherapy. So that's a lot of options for this subset. When you have unfavorable intermediate risk disease, you're falling into the same subset. So you're getting potentially a radical prostatectomy with a lymph node dissection, or if we think that you're going to live 10 years or more, external beam plus hormonal manipulation in the 4 to 6 month range, plus or minus brachytherapy. Or if we think that your life expectancy is less than that 10-year mark, observation. I'm a member of the AUA, and the AUA is another of these large guidelines, and they say the same thing. They essentially say that you need to speak to your patients about all of these different treatment options, and then the patient needs to make a decision. And in New Orleans, and those of us who have trained other places, I mean, I'm sure it's in Boston as it was at the NCI. I mean, a lot of these patients came in with, this is my stack of papers and I've done all of my research and this is what I want to do. But in New Orleans, and particularly at the VA, where a lot of my veterans have previously just sort of followed orders in their direction, they say, tell me what to do, doc, right? And it's a very difficult position to be. To be paternal, not be paternalistic and giving patients and saying, look, you have all of these options. So when you're telling the patients about all of these options, your question first is going to be, how does your treatment affect these patients? And I think one thing that we can universally agree on is that we can absolutely make life worse for patients following treatment from localized prostate cancer. And I don't think anyone's going to disagree with me on that. This was data published in the New England Journal about 10 years ago at this point. This is a retrospective analysis from the Caesar trial published out in Nashville with the Vanderbilt group, looking at how patients did in both urinary and sexual function following initial treatment from prostate cancer. This is where they started, this is where they ended. In both subsets of groups, you see a substantial decrease in overall quality of life from both a urinary and a sexual function standpoint. Okay? Like I said, when patients come in and they say, what can I do? I can say, I can absolutely make your life worse. All right? If we randomize patients to therapy, right, what happens? If you look at early on incontinence is substantially worse with radical prostatectomy, but it continues to be worse even if you go out to 6 years. This is a randomized trial done in England. We'll get back to the PROTECT trial, but this is looking at 6-year outcomes. Patients will have a worse urinary function life afterwards. They will have this, once again, this is overall urinary symptoms, so this includes things like nocturia. The first is just really incontinence. And you can see with primary localized treatment for prostate cancer, patients' lives get worse. Now, they do tend to get a little bit better, but they remain substantially worse throughout time. Overall sexual quality of life, right? These patients continue to get worse. Very early on, they get a little bit of rebound, but they continue to be worse as you go beyond that early time point. Treatment for localized prostate cancer makes patients' lives more difficult for them in terms of their urinary and sexual function. One of these things that I find really interesting is that despite all of this, mental health scores are actually relatively similar behind this. And I think that that's one of these things that makes it even more difficult, because ultimately we all adapt to that change, right? And you say, oh, I got randomized to this. Oh, well, that's just kind of my life now. And what's really impressive is that people can sort of rebound into that function. But from a measurable standpoint, patients' lives are worse from a sexual and urinary function following initial therapy for prostate cancer. What's really concerning is that when you look on the news, and these were both published within the last year about what are we doing and sort of prostate cancer. This was published in the New York Times. Not everything that we call cancer should be called cancer. This is from a long-standing debate within the urologic community saying whether or not we should consider Gleason 3 cancer even at this point in time. Does this have a hallmark? From the Wall Street Journal, I think this was last month, looking at the same thing, I guess January, but looking at the same thing, like, is there a cancer that we are trying not to treat, right? Because this cancer isn't killing patients. And when patients come in and they bring these articles with them, it's tough to give them real answers of why I'm going to make your life worse. If we ignore other things that patients are reading, not from reputable news sites, but from things like Reddit or Facebook groups, then you're doing a disservice to you and your patients. And it is fascinating the amount of data or the amount of advice that follows onto these groups. And if you are a man who can't fall asleep and it's 2:30 in the morning, you can't get in touch with me, or I'm not picking up my phone. But Reddit will have all of your answers. And so men will come in, and I mean, these are just ones that I picked out because these are men having complaints about urinary function or hormonal treatment years after their initial therapy. But it's fascinating the amount of data that's on there. So men will come in and when they read on these Reddit boards about somebody who had this therapy there or that therapy there or all of these other things, men come in and they find out, oh my gosh, that was terrible, this is awful. There is a lot of information out there to say that we shouldn't be doing things to men because we do, in essence, make their life worse with this. So if we're going to make patients' lives worse, which I think that we can all moderately agree on, is there true mortality benefit associated with treatment? And there is some randomized data about this. There have been 3 randomized trials that have looked at whether or not there is improvement in overall survival for men with clinically localized prostate cancer. The first of these, and it's important when looking through them to go back and see when were these trials done, who are these patients is. As Dr. Einstein pointed out before, you want to make sure that this subset of patients matches our subset of patients. This SPCG trial, which was published with 29-year follow-up, 700 patients who they lost none to follow-up at the end of this trial. Okay? Now, these patients were enrolled in Scandinavia in the late 80s and early 90s. What's important to remember is things like PSA weren't really widely used at that point in time, okay? This also is a Scandinavian cohort, which doesn't look a lot like my subset of patients who come in to see me in New Orleans. But they said anyone who had a life expectancy less than 75 years or who had a negative bone scan, when they were testing PSA, they said the PSA less than 50 were able to be included. This looks to me like an intermediate risk group of patients. If you look at their mean PSA, if you look at the average PSA in this group, it's between 12 and 13 in both groups. That would be your first intermediate risk factor. If you look at tumor stage, because now we're talking about whether or not you can feel the cancer itself, because when you weren't testing for PSA, this is how you would diagnose prostate cancer. 80% of these patients had clinically detectable prostate cancer. The rest were diagnosed on a TERP, or very few from PSA testing. So if that's the case, then you have at least 2 of your intermediate risk factors. Biopsy of Gleason score. When somebody gives me a Gleason score of 4 or 5 today, I ask how old is the pathologist. Those don't exist anymore. Everything's been shifted upwards. Where we are right now, this is all Gleason 6, but everyone in the 6 range is probably 7 or 8 in reality at this point in time. This is a bare minimum intermediate risk subgroup of patients who we were treated at this point in time. Now, the primary endpoint of this trial was overall survival, and you can see this is the graph of the left for men who had radical prostatectomy and the men who had watchful waiting. The overall death incidence was decreased with a relative risk ratio of about 0.75. Okay, so there was an improvement in overall survival when you take out the prostate of these men who, like I said, are relatively high risk. Now, the death from prostate cancer, and I think this is important because these are high-risk men. This death from prostate cancer, we don't take out prostates and cure men. We take out prostates and we cure some men, right? Because our relative risk ratio was about 50%. So your likelihood of dying from prostate cancer, if we remove your prostate in this subset of patients, wasn't 0 as compared to the other group. It was about half as bad. Now you can see this risk of distant metastases was about the same. And you can see what really drove here, this overall death incidence, this 12% decrease in absolute value is mimicked in this death from prostate cancer. So we are probably saving patients' lives from prostate cancer by removing prostate in this subgroup of patients. That was done in the late 80s, early 90s in Scandinavia. In the US, we decided that we wanted to do the same trial, and I think it's important that we tried to do this. We enrolled 731 men with clinically localized prostate cancer. Now, our goal in this group was 2,000. In the US, where you can say, I don't really want to be randomized, I'm just going to go get my prostate out, very few patients accepted this. And so there is some issues with this being an underpowered study. Enrollment time. So you see the first patients were enrolled in the 90s. We were already using PSA testing at this point in time. So we were starting to find men with clinically smaller prostate cancer. And like I said, this is a very similar cohort of patients in terms of inclusion criteria. Now, if you look at the intermediate risk group, there were some with low-risk disease, but your median PSA has dropped pretty substantially in this group, right? It's gone down from 12, this is 10 for the mean, about 8 for the median, similar between the two groups. And if you look at the true NCC and intermediate risk, about a third of this group would be considered intermediate risk in our hands. And I think that's probably a little bit more representative of an actual intermediate risk patient today. When you look at their overall survival, there probably is a small benefit if you bring this out further and you had a full value, but your relative risk ratio is about, here it's 0.92. It wasn't clinically, statistically significant in this subset of patients. Your death due to prostate cancer, your relative risk ratio was a little bit stronger. Once again, the confidence interval crossed 1. Statistically, there was not a difference in prostate cancer or overall survival in these two groups. Now, one of the other major plagues about this trial is one of the inclusion criteria for these men was that we were expecting them to live 10 years. But if you look at your 10-year mortality associated with this, 30-ish% of the patients have already died at 10 years. That is a huge percentage of men who you expected all of them to be alive at 10 years because they're not dying of prostate cancer, right? These are men who are dying and who have increased comorbidities associated with their overall life. Now, if you look at the forest plot and subdivide it out, the only subgroup where there's any real improvement is those patients who have intermediate risk disease here. Well, when there's two trials that sort of say slightly different things, we get another trial. And this third trial was taken from England. And these are men, this is a wonderful things about socialized medicine is you can kind of tell people what to do. So they initially randomized men to PSA testing, and then they took the men who were PSA tested who had cancer, and then they sub-randomized them again. So it's about 1,600 men, once again, 10-year life expectancy, PSA less than 10, negative bone and CT scans, right? This isn't PSMA era at this point in time, but you look at your overall mortality at 15 years, and there is I can't even get my laser pointer between those lines, okay? There is no difference in overall mortality at 15 years. Really concerningly as well is that when you look at these subset of patients in prostate cancer specific survival, there's no improvement in overall mortality at 15 years with either radiation therapy, because they randomized patients to radiation therapy in this subset, or with radical prostatectomy. 15 years down the road. Now, we all make the arguments, we'll wait for the next publication of this, they'll get to 20 years, they'll get to 25 years, maybe we'll start to see those curves open up a little bit, but there's not much of a signal there. If you look at this subgroup, and now these are truly intermediate risk patients, and that's the D'Amico intermediate risk subcategory very heavily corresponds to the NCCN guidelines. These patients, your confidence intervals are kind of all over the map. In this subset of patients who had intermediate risk disease, we are not making very much headway for treating them by removing their prostates or by offering them radiotherapy. There's a lot of discordance for trials. Like I said, the era of treatment is different between these three trials. They were done decade, then decade, then decade. So there's a slight change associated with that. There were also slightly changed clinical risks of these patients, right? You were talking about a much higher risk subpopulation in that first group of patients than you were in the second group of patients. And then third, there's a change in the health of these patients, right? The mortality in that third trial at 10 years was substantially less than the mortality in the second trial at 10 years. You have to find patients who are going to live 10 to 20 to 30 years to really benefit from prostate cancer treatment. And I think that comes down ultimately to patient and patient selection. But that doesn't leave us any closer to where we really want to be, because now when you sort of summarize up all this data, we think that there's probably a role with intermediate and high-risk cancer-specific survival. There's probably a benefit there if you look at all of those trials. Counseling patients in general requires that you tell them we are both potentially over and under treating you with this disease, right? Even in the highest sub-risk group of patients, you still saw 1 in 5 men who had a radical prostatectomy die of disease at 23 years. We are under-treating them at that early time, or they're non-curable at that point in time. So I think that our real hope at this point in time is identifying the most aggressive tumors that will help to improve the oncologic outcomes. And so, how do we identify these more aggressive groups? Well, we can either change what we're doing for screening, right? We can improve our detection mechanisms, or once we identify the cancer, we improve our stratification of these patients. Because at each of these 3 time points are really when we can say this patient is higher risk versus not higher risk. This is how I feel about prostate cancer screening. I am glad that these patients come back to me after their PSA has been checked. There is so much conflicting data in this space. The US trial shows there might be a benefit. The European trials show there probably is a benefit, but we're just skipping that. That's beyond what we're willing to do today. So then if we're moving beyond that, because this is the cancer advocacy group, we are assuming that patients have that diagnosis of cancer before they come see us. And then we can look at the stratification after that. So if you're identifying patients, we should be looking at, and these, it doesn't look like it came out very well, but this is from the Martini Clinic in Germany. This is 12,000 patients who had a radical prostatectomy. What you can see is that up top, this is Gleason 6, Gleason 3+4, 4+3, Gleason 8, and Gleason 9. Okay, and that's pretty standard. You can see that if you're curing the vast majority of patients, then you're probably over-treating them in some capacity. But as we look at how we diagnose patients, when you subdivide that 3+4 into high volume 3+4 or low volume 3+4, you start seeing those curves really spread out a little bit more. And when they have 12,000 patients like they do at the Martini Clinic, you can look at that subgroup of patients and you can really see who are the absolute highest risk patients. And those are the patients who have more primary 4 than they do anything else on their disease. These are the patients, this high risk or higher risk subset of patients that we need to be identifying. The best and most impressive tool that has come about in the last 15 years for prostate cancer identification has clearly been MRI. MRI is very good at, number 1, identifying patients who need a biopsy and cancer detection. And then number 2, identifying patients who you're going to find non-clinically significant prostate cancer, because we don't want to be telling patients who have cancer that's not going to kill them that we're going to do something to harm them. And like I said, this was the randomized trial that came over from Europe. The positive predictive value of a multiparametric MRI is not great. That's why we have Likert scales associated with MR-associated lesions, a 3, a 4, and a 5, based on that. The negative predictive value is very good for men following an MRI. And utilizing the MRI helps us identify those higher sub-risk groups of patients who have cancer. Now, what's really fascinating, and as you dig into the MRI data, it gets even cooler, is that the MRI by itself actually can help you look at there is some level of radiogenomic assessment there. And we haven't been able to do it, and there's a bunch of AI companies that are really trying to figure out how to do it. But if you have an MR lesion that looks like cancer, and you compare it to a patient who has a lesion that is not MR detectable, those patients do worse, independent of everything else. This is a cohort, it's about 1,300 or 1,500 patients from Memorial Sloan Kettering who had an MRI prior to. When they have an MRI that shows something that's detectable, these are the patients who recur. MR detectable disease confers increased risk of disease progression, and utilizing that to identify patients who are at higher risk is absolutely necessary for improving outcomes in this intermediate risk group of patients. That's looking at localized disease, and you can also translate this to whether or not that disease is actually extending outside of the prostate. So for MR detectable disease, these patients do worse following radical prostatectomy because they have MR detectable disease. And we don't really know why that is, but we do know it's associated with that. I think there's other imaging technologies that are around the corner that we'll be able to use in time. And this is a screening subset from Australia. It's about 200 men, all of whom got PSMA as part of their primary screening analysis for prostate cancer. And you can see as you become higher and higher and higher grade cancer, that SUV max increases, and you are more likely to find clinically significant cancer in men who have clinically localized disease with a high SUV. We are going to do a better job of detection in the future. Biomarkers. There are a lot of biomarkers out there, and utilizing these biomarkers to help improve our disease stratification is one of those things that's going to help keep our patients from being harmed by what we do. There are a lot of biomarkers that are available in the risk stratification space, helping us to say whether or not the genomic architecture or the genomic alterations associated with your disease do or do not harbor similar traits of patients who have had progressive disease in the future. There's about 5 or 6 in this subset. In addition, there is now the Decipher test is actually approved to look whether or not you are more likely to respond to radiotherapy following treatment. And even more exciting is the future, because now there are ongoing trials utilizing the genomic testing of men to see whether or not in intermediate risk disease we can give them more or less hormonal treatment during therapy, using a Decipher score of 0.4, which is about the middle of the range for them. So that brings us back to where we started, which is what is personalized treatment for men with clinically localized intermediate risk disease? And I think that when I talk to a bunch of oncologists about this is what they're thinking about. They're thinking about, great, we're going to find that targetable option. We are going to find that BRCA mutation. We're not going to use the ATM mutation. And we are going to give patient-specific drugs based on this. I think that if you're a patient, it looks a little bit more like this. Because ultimately, we need to get you into that place till you get treatment. And for a lot of patients, they're not ready to accept the risk because they don't understand a lot of this. When you look at, this is a survey-based trial that was published a couple of years ago, a lot of men are willing to give up quality of life, are not willing to give up quality of life to extend their overall life. The worst of these is severe urinary leakage. Men say, I would rather die 3 years earlier than wear diapers. The difference in overall survival in the best of those studies is close to 3 years, right? Men don't feel comfortable with some of these decisions, and so for personalized therapy for these subpatients is difficult, and it's sort of figuring out, is there a way that we could decrease our level of invasive treatment or make our side effect profile better? One of the things I focus on, generally speaking, has been some of the ablative techniques for prostate cancer. And these are 2 or 3 year outcomes from 650 men following HIFU, which is localized ablation of their disease. We're saving them from a urinary continence standpoint, and also from an oncologic standpoint, but that isn't randomized data. And so really where I think the future is, and what I think everyone's very excited about, is starting to see what happens in the future for randomized disease for these men, because personalized therapy for these patients isn't what we're currently doing. And so because we're offering men very aggressive local treatments that lead to worse quality of life without a substantial increase in quality of life to many of these men. So there are active ongoing clinical trials. This is the PRIS trial. It's randomizing IRE versus radiotherapy versus radical prostatectomy in a subgroup of men. I'm excited to see the results of these. For men with intermediate risk disease, personalized care really is shared decision-making with the patient. It's really sitting down and going through these numbers to make sure that men understand that the mortality benefit is moderate. It's not a cure oftentimes, and you have to select the exact right patient in order to see this mortality benefit associated with their therapy. Thank you, guys.